If you love the conversations we have here on The Ortho Show, you're going to love what's coming next. Consider this your official invitation to join me on Smart Medicine, a brand new podcast at the intersection of healthcare and innovation.
From medical media, this is The Ortho Show.
Hello world, Dr. Scott Sigman, your favorite opioid-sparing orthopedic surgeon here for another episode of the Ortho Show podcast, where we bring you the best of the best in the orthopedic world, and today is no exception. Today is actually a pretty special episode. We're going to focus on the rationale for rotator cuff repair augmentation, and we are powered by Anika. We have two absolutely outstanding orthopedic surgeons that are joining us today to share their philosophy on rotator cuff repair. So let's start with our dear friend, Dr. Timothy Codd, who's an incredibly well-respected shoulder and elbow surgeon who lives in Baltimore, my hometown, private practice at Towson Orthopedics, and is also affiliated with my alma mater at the University of Maryland Medical System. We are contemporaries, which means, Tim, that we are old. So we're going to give some shout outs to Columbia, which is a big fan of mine. I love Columbia Orthopedics. We've had so many on. You did your residency there. You did your fellowship there in 1993, 2 years before the Professor Bill Levine, who's a dear friend of ours as well. So, Tim, welcome to the show, brother.
Thanks for having me, Scott. Like you said, the dinosaurs are back in the room again, but the dinosaurs have learned to adapt. We will not be extinct.
I love it, man.
We're going into biology today.
I love it. That's exactly right. We've got full head of hair. It's all gray, and we're willing to adopt. I love it. Next up is a brother of another mother, Dr. Christopher Baker from Tampa, who's a shoulder and sports medicine specialist from Tampa at the Florida Orthopedic Institute. Chris did his residency at the University of Pittsburgh with the great Chris Harner and Freddie Fu, and then went on to do his fellowship at Stedman Hawkins of the Carolinas with Hawkins and I think Tokish. Chris and we have overlapped so many times in our desire to provide patients the most innovative solutions in orthopedics. Welcome to the show.
Thank you for having me, Scott. Yes, we don't share hair, but we definitely share a passion for trying to improve our outcomes.
It is so true, man. We have done a lot of great projects together. All right, so welcome to the show, boys. Let's start off with the why, okay? So let's talk a little bit about why we think we need to add biology to rotator cuff repairs. I always say this, I've said it many times, the first 20 years of my clinical practice, I was a mechanic. I had screws, I had anchors, and I just would mechanically fix things. In the last 10 years, I've truly become a biologist, trying to biohack the body to help us to create healing. So I say out loud, why do we call these things rotator cuff tears when most of them have not actually torn? They've just failed. It's a failure of biology. So the question is, why put the rotator cuff back into the same place where it had previously failed and expect a different result? Chris, what are your thoughts?
I think we're of the same mind frame. I think people who tear their cuff have a pathological process, not an injury. And I think fixing the injury is an easy thing. Fixing the pathology and the biology is not. Of all the surgeries I do, the one thing I expect to fail are my rotator cuffs. And I don't feel right about it. So I'm always trying to get it better and see what we can do to improve it.
So Tim, we've been around a long time. We've been doing this a long time. And let's be very frank. We weren't really very good at rotator cuff repair, right? If you really take a deep dive in the literature, we had high failure rates, right? I mean, it just didn't matter what you were doing, single row, double row, it didn't matter. 20%, 30% failure rate for our biggest tears. So what is it that you're doing now that's different, that's helping you to make a better outcome for your patients?
Well, I mean, you hit the nail on the head. I mean, we can put something back, and maybe if we take some of the strain off it, that'll be helpful. But it failed for biology as well as mechanics. I mean, these things, you look back at the literature from back in the 80s and the 70s, they talked about losing blood supply, things getting attritional. You do histology, the cells are dying off. It's basically like worn out fabric. Once you get dry rot, you can't stitch up dry rot. Well, you can, but it doesn't work, which is what we found out. So what can we do? Let's make our fabric regrow. Let's make our fabric better, and that I think that's the whole giant new frontier of orthobiologics and, basically uh, medical healing versus mechanical healing that we're trying to get into now.
It is absolutely revolutionary in our, 35 years of practice at this point, what we're doing now, compared to what we were doing before. And really at the end of the day, it's almost like a stall, like the body stalls, like it knows what to do. If you could just stimulate it to heal, it'll do it. But for whatever reason, this chronic inflammatory state, the healing, sort of stalls. So let's now talk about the what, okay? So what I mean is, what are we going to use to be able to help our body to heal? All three of us have extensive experience with bovine collagen-based products for orthopedic bone tendon surgical augmentation. We were some of the earliest adopters in that concept almost 10 years ago, maybe even a little bit more at this point. So I really want to sort of take a deep dive, at this point into the difference about what the Anika Integrity Implant is doing. So I did what everybody does now, including my kids and my wife, and I went to ChatGPT to get some good answers to talk about what HA, right? So hyaluronic acid, which is what we're going to be doing a lot of talking about. So I figured just to sort of educate our listeners, HA is a naturally occurring glycosaminoglycan. Means it's got sugars and it's got proteins. We talk about essential amino acids now and peptides and all that stuff. Well, that's what sort of HA is. It's a naturally occurring product. It's in our joints. It's in our skin. It's in our eyes. So it's ubiquitous in our body, which is really quite unique compared to perhaps taking collagen from another species and using it. So, Chris, talk to us about the makeup of this integrity graft and why it is unique in the marketplace.
Yeah, so the whole reason we're able to even talk about this is honestly the technology that Anika has patented in modifying the hyaluronic acid molecule itself, creating it from this gel that we're all pretty familiar with and turning it into basically whatever they want. Through an esterification process, they're able to link this thing and make it into a solid. They can make fabrics, they can make fibers, they can make films, they can make all kinds of things that they want to do. So what they've done for us is they've made more or less a woven material that has a little bit of polyethylene in it that gives it a little bit of time zero strength, makes it a little bit more manipulatable and a little bit easier to use. And then that will basically be rapidly absorbed just like hyaluronic acid in the body. The issue is that the liquid form will basically break down more or less right away within minutes to hours, whereas this solid form can last a much longer time and then break down through normal healing process. So it's a pretty unique product that's been out there in the knee world, the hip world, for cartilage restoration for the past 20 years. We're just now bringing it to the shoulder and kind of breaking through in that market now.
Dude, for an orthopedic surgeon, you sound really smart. I mean, there was some really good science there. So
I read the paper. I did not write it.
No, it's okay. That's good enough. The fact that you did a great job. We appreciate that. So for our listeners, again, I think when you take away from this graft is that you have both biology and you have mechanical support. So the polyester that goes in there, which is sort of like rebar through concrete, if you will, it actually helps to create a suture that you can sort of pull into or tacks that you can put into. So you can suture into this thing. And then you've got the biologic aspect, which is the HA. And Tim, I want you to take a deep dive on that for us as well. Everybody knows Professor Bill Walsh, who's the Australian dude with the New Jersey accent. He moved down there 30 years ago, right? But he's the guy. It used to be Arnowski, but now pretty much Bill has taken over. If you're going to do a biologic study in preclinical studies as a veterinarian, you want his opinion to be able to share how it may perform in humans. So give us some of the data on Bill Walsh's work.
Yeah. So, I mean, you mentioned two of the people that I respect just because, when you stand in a room and you look around and say, these people are really smart. One of them is Steve Arnowski, who I had the pleasure of working with. And now, Bill Walsh, as you say. So Steve looked at these things early on and said, you know what, when you try and use dermis, it doesn't do anything. So we said, okay, let's try and use, bovine collagen, and it worked pretty well. But even, our early studies, some of the work by Schlegel, you look at the number of cells that come in, you look at the type of cells that come in, and they do a nice job. And they're usually on one of the surfaces of a graft that you're putting in. The problem is, you want stuff to grow as much tendon, as much tenocyte like cells as much strength as you possibly can. So what's really exciting is you look at hyaluronic, like you mentioned, it's everywhere in the body. They're using it for regenerative face creams from the cosmetic industry to try and get skin to look better. But anyway, so we put it back in an animal model, and what's awesome is you got cells growing both on the side that's attached to the tendon, and you got cells that are growing on the side that is exposed. So if you're trying to make an interposition graft, you're trying to make an onlay graft, what you're going to get here is more tendon-like tissue, more strength, more protection at time 0, time 10 weeks, time 12 weeks. And I think this is what's going to help us, get these things to heal.
Yeah, no, I love it. We were all very early adopters, right? And so it was freaking rotten tomatoes when we would get up and start talking about rotator cuff augmentation. I'm like, what do you mean? What a concept, right? And so we started off, but now just about every major company has some sort of an implant that they're selling for augmentation of bone tendon. So let's run through it. You talked about skin. Arnosky showed that there's some good data for dermal patches. I mean, it's been used for a long time. The issue isn't that you can't sort of get a rotator cuff to sort of come together. The issue is the skin never goes away, right? It's always skin. If you take a look under the microscope, it's still going to be skin. And the idea is, can we get the tendon to really become a tendon? So now there's like synthetics, and some people want to put it on the top. Some people want to put it on the bottom. Then there's synthetics with collagen, right? The BioBrace. Then there's collagen alone, which is the Regeniten. Now you've got a bone mineral matrix as well. And now, I don't know if you guys seen it, but the sewing needle, there's a synthetic with a sewing needle that goes up and down, and you can like push this thing in. So it's really impressive how many implants are out there compared to where we started. So, Chris, give me your thoughts as to why you really like Integrity for what you've seen in clinical aspects.
Well, I think it's multifactorial. Like you said, I think all of us on this call have really worked with all the stuff out there. I was a big dermal guy because that's what there was originally. That's kind of the first augment that there was. And it was kind of like a washer effect is kind of how I looked at it. It helped kind of sutures pulling through crummy tissue. But the biologic effect had some difficulty, obviously. It was also technically difficult to do. A lot of guys have a hard time with it. It adds a lot of time to your surgery. So if you're running late in the OR, your day's getting late, you're like, I'm not going to put a graft on this thing, So then when the Regeniten came out, I was more concerned about that time 0 strength, but it had a pretty cool ability to put it in, did it quickly. But I wasn't seeing improvement in my large repairs. So my large tears were still failing. So I kind of relegated it to partial tears in my practice. So I was still kind of back to using these dermal grafts or kind of doing nothing, more or less, just trying to do a low tension repair. So now that I think we've been using this for a little over a year and a half with the hyaluronic acid based implant with Integrity, and our MRIs are looking good and patients are doing well. We're working on a prospective cohort study and things are going the right direction.
All right, old man Tim, what do you got for me there, brother? You've been through the whole thing as well. What are you seeing in Integrity now with your patients?
So, yeah, I mean, let's get technical about how we do things. We're orthopedic surgeons. If somebody says, give us a big hammer, give us some nails, and we'll pound on them. So, as somebody who kind of worked on the early stages of the bovine collagen, it was fun. I love it, but I was like, it's not doing all I need it to do. I would tear, staples out, I'd try and move it around and rip it. Which you can work around it, but it's not a good day when that happens for you. And as you mentioned before, we're using the dermals, and I would go back in there. So some of the people that would fail, and there'd be this big giant sandwich of dead tissue floating around that I'd pull out that looked like a postage stamp because it stayed inert, internally. The advantage I think we're getting with this, newer materials and newer technology is, here we're putting things. We've got a 47% stronger tear out of the initial implants. I can move it around. I don't worry that I'm ripping it into pieces when I'm trying to position it. And I think positioning is important. As I said, you want to get it in the right place to get the biology, but you also want to get it in the right place to kind of unload mechanically some of the strain. Because I think if you look at some of the modeling, and again, we're getting way deep into the woods here of physics and engineering, but if you unload some of these tendons, and you can see that on these strain curves that you can generate in an animal model, you give that area protection long enough to grow into something that will stand up to years of use. And I think that's where we're really moving forward here.
Yeah, and to be clear, I mean, there is some really good data on dermal grafts over time as an augment to improve rotator cuff healing. There's some really good data from the Regeniten implant showing, improved healing with rotator cuffs. There was a new study that just came out of Spain. So it's not like these things aren't working. What we're doing is we're evolving here as we continue to work now from mechanical and then working our way into biologics as well. So, it's a good segue because the Regeniten does have a pretty cool instrumentation that allows you to put it in. We all, we're part of that. So let's talk about the how, right? How we're using it, because I think instrumentation is important. There's only a few implants that actually have an instrumentation model at this point. So Chris, describe, because you were really integrally involved in the design concept of the instrumentation. Tell us how easy it is to use, how facile it is, how reproductive it is.
Yeah, so
reproducible.
Yeah, that was the issue that I had with, again, like you said, the dermal implant wasn't not working for me. It was more of an issue of speed and time, right? So we wanted something we could do quickly, like the Regeniten, that would give us some biology as well. One thing that I had an issue with occasionally with the Regeniten is as you start inserting your staples from the medial side, sometimes you'll start kind of migrating the whole implant medially. And as you get to your lateral footprint, lo and behold, you're looking at the tendon bone junction that you're actually not covering. So if you've never had that happen, that's an embarrassing moment in the OR. So what we tried to do is make this step by step without extra steps necessary, but working from a lateral to medial direction if possible. So as you stick the implant in, your implant goes in with your lateral bone staple and it anchors it laterally. One step done. Then you're simply tacking the tissue down to the implant. And it's all one step. There's no like punch, dilate, insert. It's just insert, dilate, implant all at the same time. And again, by going from that lateral position to medial, you're not going to migrate your implant medially over the soft tissue and miss your tendon bone junction.
Tim, you've had a lot of experience with the instrumentation as well. What are your thoughts?
Yeah, I mean, I love what Chris is saying. I think that was one thing that I had problems with, where I would cover stuff up and I wouldn't be exactly sure that I'm getting the bridging of that bone tendon interface. And I really do like this ability to put it in laterally. The cool thing about orthopedics, about these grafts, is if you give orthopedists a tool, they're going to find lots of different ways to work with it, So this is one way to work with it, the way that, kind of designed by some people who thought this was something fun. But we're seeing people out there now who are saying, you know what, I'm putting in lateral row, medial row stitches. Let me just stitch this down. And if they find a way to get this to work that works better for them, as long as you're getting your biology where you want to and you're holding it how you want to, I think you're accomplishing what we're looking for. A better healing environment, a better way to get tendon tissue to kind of fill in and give us the repair that's going to stand up over time.
Yeah, it's reproducible. It's something that's very, straightforward. You should be able to get this graft in within 10 minutes and, no issues as far as that's concerned. So I agree. So well done to you guys in the design phase of making the instrumentation. And I'm sure they're going to be working on improvements because that's what medical device companies always do. So, all right, now let's talk about the when. Okay. So, I think it's when it comes to rotator cuff disease, there's a large spectrum. And I would say this, if I'm the CEO of Blue Cross Blue Shield, I'm going to say this out loud and people make fun of me for it. I don't care. 5 years from now, if you're billing a 29827, which for all of our listeners is an arthroscopic rotator cuff repair code, I'm not letting you do the surgery unless you have added augmentation. So I've said it out loud. So now let's talk about the spectrum of rotator cuff disease, right? We have tendinopathy. You see it clearly. Patients have pain. There's not a tear, but there's changes on the MRI in the tendon. Then we have partial tears, which can occur below the tendon on the articular side. It can happen on the bursal side. We've all seen it happen on both sides where it's like literally just sort of hanging on. Then you have a full thickness tear, which is everybody says, oh, those are the chip shots, 1 to 2 centimeters. I don't need a patch for that because I can repair it. And then you've got the massive tears, which have really been the ones that have really been difficult for us. So Chris, walk us through how you're using augmentation and rotator cuff across the entire spectrum of disease.
I think there's really, in my mind, when it comes to this problem, there's traumatic and there's non-traumatic. So to me, if I have a true traumatic injury, the guy is a 50-year-old guy. He decides to take that downtown moto scooter for $1 off the corner and decides to jump a curb with it and lands on his arm. That guy comes in with an acute tear. That's the guy that I'm doing a primary repair. There's no need for augmentation. We're dealing with a true injury. That is the vast minority of my patients. And I don't want to drink your Kool-Aid, Scott, but it's becoming my patients. Okay. So then there's the non-traumatic, right? So the 37-year-old girl, I had a 37-year-old female last week who has an atraumatic rotator cuff tear. It's a small full thickness tear. And when I talk to guys about this, it's like, oh, she's 37, she's young, she's going to heal that. Wrong. There's something pathologically, biologically wrong about that 37-year-old mom who has a traumatic tear to the rotator cuff. That is not normal biology. That's the one that you're going to repair. She's going to come back in 3 to 5 years and you're going to say, well, what happened? It decompensated, it never healed, and now you got a large tear. So those are getting an augment. Partial tears are getting an augment for me. I'm no longer doing pasta repairs or taking down and re-repairing. They get a partial repair. They're out of their sling in a day or two, and they're moving their arm. They're getting back to life. My large repairs, failure rates are through the roof. We're going to do augments on that as well. I don't modify my PT on those patients, but I do let them go once they get moving after that 6-week mark. So it's becoming my atraumatic repair management, not my traumatic repair management. That's really kind of how I differentiate the two.
Yeah, I mean, I think what is the definition of insanity? Doing the same thing over and over again and expecting a different result. Yeah, you have a 2-centimeter tear in a 37-year-old woman. This is a biologic failure for her. Yeah, it's super easy to put a couple sutures in and do a one or a single row or double row repair. But why are you going to anticipate a different result? You have to stimulate. You got to hack the body's ability to repair, and you got to add biology. Tim, same thoughts across the spectrum of rotator cuff disease.
Yeah, I mean, you touched on it wonderfully. I mean, if we're looking at this as clinicians and trying to get somebody to heal, we should probably be doing something biologically to everybody. Anything we can do to help them heal better is good. I won't call people out on this webcast here, but there's some people in my neck of the woods who basically are putting a graft on every single rotator cuff from, mini tears to partial tears to massive tears, and I can't argue with them. Now there is the finance part about this, which is something where we have to educate the world, but where I started with was the partial tears, because I knew 58% of these folks were going to progress in 12 to 18 months to a full thickness tear, and in situ repairs, takedown repairs, they did okay, but they didn't do great. We couldn't prove anything. And if you look at the Australian data, the partial tears, the pasta series they did, they actually went and looked back, and you could see the tendon getting thicker. You can see the strain going away and see them healing. Now, at the other end of the spectrum, as Chris has said, I'm putting them in these massive tears where I know I'm going to have problems with it healing. We look at all our literature, failure rates of 20, 40, 60%. That's not acceptable in any medicine. If I told my plumber he's going to, screw things up and it's only going to fix my pipes, 40% of the time, I'm not going to pay him to do his job. So I think we're going to find we're going to do this for, a lot more people, a lot more often.
One thing on that, to not to cut you off, Scott. So, I think a lot of surgeons don't get imaging on patients, right? So I think it's how we define failure, right? So our shoulders do well. When we operate on our shoulders, most of them do fine. But how many of us get MRIs after surgery, right? Those papers that have looked at failure rates did that. They followed patients for 5 and 10 years and got MRIs, and they were finding tears early and often. And most of us don't do that because we don't want to know. We don't want to peel back the curtain and look what's under there, right? And if we do that, and I think a lot of us that are on this call, we are involved in studies and we're doing research and we're looking at outcomes and we're being critical of ourselves. And it's hard to accept that what you do that looks so pretty at time zero fails. And if you have the guts to look at a post-op image of your patient, which is hard at times, you're going to see a lot of failures. And I think that's the disconnect between those of us who are interested in this idea of augmentation and the naysayers that say my patients do fine. Yeah, I think that's a difference.
Yeah, no, I think that's, excuse me, exceptionally well said. I think it's fascinating because I think we should probably all be ultrasounding our rotator cuffs as we go through the healing process. I am not. I missed that generation, but my nurse practitioner is pretty good at it. But guys like Donnie Buford, Greg Colbath, they're literally ultrasounding every post-op image when the patient comes in for follow-up. That's a great way to be able to follow it as well. So really a great point. All right, so let's talk about the future because the three of us are involved in the future of this, product as well. You've given us a description of the stuff, again, which is HIAF, which is this proprietary biomaterial from Anika that's derived from HA, and then it goes through this whole esterification process and all this other stuff. The bottom line is you can take this stuff and make it into a lot of different things, right? So sleeves, tape, suture. I mean, and then maybe you could even do it at less of a cost, right? And then you're still adding biology. So Chris, give us your thoughts on the future of how this HA product might be able to work.
Yeah, so I think we're really just kind of touching the surface here. I think it's really been used in a limited fashion, for lack of a better word, in cartilage restoration in Europe. We're just now kind of starting to test that management of this material with tendon healing. What we've done here in Tampa with our early experience, we looked at 10 patients and we're seeing thickening of our tendons. I think our initial tendon thickness was around 4 up to 7 millimeters now with really good incorporation of this. I think as we show in prospective cohort studies that we're seeing improvements and as we start to apply it in different ways, I think the sky's the limit in ability. So this could even leave the tendon market and go into other soft tissue forms of healing. All of these connective tissues are HA based. All of these connective tissues have hyaluronic acid in them. So any repair process that we perform in the body potentially could be improved by utilizing this material. It's a really kind of a unique situation we're in.
Tim?
Yeah, I mean, again, it is one of these things. We're in the dawn of a new age, of terms of biological healing. And where can we use it? What can we do with it? As you mentioned, Chris, is that think about it. We used chromic gut to stitch up people's bellies years and years ago. We moved into Vicryl because you can get more strength, but it still dissolves. Let's get stuff now that as it dissolves, it creates new tissue. So the idea of being able to use tapes and sutures for this, it's exciting for us. The idea of saying, back to my analogy of fabric, if I have my dry rotted fabric in a big hole, I probably need a patch on my jeans. If I have some jeans that are getting a little frayed, can I use a couple little whip stitches that will bring in some more tendon and help my little fibers grow to where they're supposed to? Maybe save a couple dollars, maybe make everybody happy at the same time. I think this is going to be basically game changing for some of the things that we do right now.
Yeah, I'm going to put my CEO hat back on for Blue Cross Blue Shield. I'm going to say to you, hey, Chris, you got that acute rotator cuff tear that you're talking about. You don't want to patch it, but why not use a tape or suture that's made of some stuff that's going to create increased biologic healing? Maybe you're not going to do a patch on it, but add the biology through the suture and the tape, right? I mean, that would be pretty cool. And then, if I'm the CEO of Anika, I know you're listening, Cheryl, the idea is, can we create these products that may be able to then reduce the overall cost at the ASC, which is where these are being done at this point. Reimbursement is not going up at the ASCs. It's only going to be staying even with the new geographic rules from CMS. So the bottom line is we need to be cost effective, create value care. So if we can create some of these products that are not going to break the bank at the ASC, we'll probably get a lot more surgeons that might be interested in using these. Thoughts?
Yeah, great, kind of synopsis, Scott. I sat on the Adirondack chairs with a cocktail with the CEO of Blue Cross Blue Shield of the Mid-Atlantic, and he said something to me once. He said, Tim, it's the only industry in the world where the payer and the consumer are entirely different people. And the consumer wants the absolute best quality, and the payer wants the cheapest cost, and the two have to meet somewhere in the middle. So if we can find a way to do these things with efficiency, economy, but not sacrifice quality, I think everybody's going to be happy. And I think that's what's really exciting about what Anika is doing. I think they're trying to work with us, work with the industry to give us a spectrum of things that we can use to help heal, but still, work with health costs in the United States. It's a real issue, and we have to be cognizant of it.
I can guarantee you that CEO of Blue Cross Blue Shield is going to be asking for an implant when he gets his rotator cuff done. So that's when the payer and the patient and the consumer come together. So, all right.
Yeah.
So, Chris,
he was a Division I basketball player and a pretty
yeah,
good golfer. He wants to be able to do what he's supposed to do.
exactly. Give me that implant, dude. I love it. All right, Chris, give us some final thoughts here as to where this is going, the future of augmentation and rotator cuff repair.
Yeah, I think again, it's all about following our patients and improving what we do. I'm really happy that we have support from Anika and the research team there, that they're putting their money where their mouth is. I mean, right away, we're already collecting patients. We're already trying to get data out there, as opposed to getting up a bunch of numbers and then coming back in a couple of years if it seems to work out. So we're going to start getting stuff out there immediately. We're going to start collecting and publishing data, imaging, outcomes measures, all that kind of stuff from the get-go. So I look forward to what that shows in the near future.
Yeah, I mean, data does not lie, right? And we are the tip of the spear at sports medicine. Everybody wants the randomized controlled trial. I always say in sports medicine, by the time the randomized controlled trial comes out, we may already be moving on to something else. But I do think that research is king to be able to demonstrate and show the things that we are doing working. Tim, you got a couple final thoughts for us as we go?
Yeah, as you said, facts, move the world. If you look at level 1, level 2 evidence-based medicine, that's what's supposed to tell us what we do, And the problem now, we've got all these studies where people are aggregating things and trying to get big data out of multiple different types of studies, but still the gold standard is what we're trying to do here. Is say let's follow these patients. Let's show with imaging. Let's show with patient outcomes that we're helping them get better. And right now our early results look promising. But we want to be able to prove that, and we want to be able to show that this is the next step forward.
Innovation takes courage, and the two of you are filled with innovative courage. I thank you both so much for all of the work that you're doing to influence the way in which we're caring for our patients and improving patient outcomes, most importantly. Thank you to Anika for powering our episode today as well. This is Dr. Scott Sigman, #FollowTheFro, host of The Ortho Show. Till next time.
If you love the conversations we have here on The Ortho Show, you're going to love what's coming next. Consider this your official invitation to join me on Smart Medicine, a brand new podcast at the intersection of healthcare and innovation.